All right, I'm going to try it. Hello. We're ready to go. I try not to present you with an overwhelming amount of technical information if you can accept that. Everybody scoots in. All right. So this is, we'll go through all of this stuff. This is kind of, we talk about therapeutic index and safety margin, as I recall. And everybody did a Kirby Bauer test in lab. So that's why I wanted to get that part in. And so this is, and the only hard part about this is I'm going to try to frame it so we don't have to get too heavily into the different antibiotic categories and save that for the future because it'll be easier, I think, if we do it that way. So, I mean, these are all the things, and it's not just the physicians, nurses, anybody who interacts with the patient. All of these are significant factors. It's all about making a choice. That Kirby Bauer test just tells you here are your available choices. Okay. And the question is, how do I decide which ones to use and which ones not to use? And trust me, everybody, the first, I mean, other than obvious things like being allergic to it, the first criteria that you're going to get to is bactericidal versus bacteriostatic. And we'll go over all of those when we get into the individual categories of the antibiotic agents. So, first of all, I mean, that's the whole idea. Why you take a history. So, pre existing conditions are part of, for instance, diabetics have, the longer they're a diabetic, they have bad kidneys. How do we basically clear most antibiotics out of our system? From the kidneys. We urinate them out. Okay. Effectively, the liver might break them down, but effectively, what the liver does is make them compatible so they can be excreted in the urine. Okay. And so you have to take that immediately into account. Some of these have some antibiotics have a very high, we talk about sodium all the time. Sodium is a burden on your kidneys. Some of it they have to get rid of it. Some they have to reclaim it. Sodium moves things around, as you see when we get an A and P to urinary tract or renal physiology. So that puts a burden, and you have to adjust the dosage with regard to that because it's not going to get out of the kidneys fast enough. Allergies, and notice they framed it really well. Class, and I mentioned this when we were in lab yesterday to my lab. Okay, for instance, we tested, and I'm sure most of you tested the same agents we did. We happened to use penicillin, ampicillin, and C-chlor. C-chlor is a cephalosporin. There's what we call it, and I'll reiterate this point down the road when we get to really to maybe the most important category to discuss, cephalosporins. There's a 10% cross reactivity with penicillins. That means if you're allergic to penicillin, there's a 1 out of 10 shot you're allergic to something like Keflex or C-chlor, which are go-to agents. They're slam dunk agents that every doctor uses. What's what? Well, there's only 1 out of 10. Only 1 out of 10 is not a good number. If it was 1 out of a million, that might be a good number with cross reactivity. When I would have a patient and say, "Oh, well, doctor, this is an elective surgery. How likely is this to succeed or to fail?" And I said, it's about. If I would tell them it's a 90% success rate, that's not great. It's a 1 out of 10 shot that you could have a bad result. A 1 out of 10 shot somebody could die from an allergic reaction. It's not good. So understand that allergy. When I say certain classes of drugs, you have to be aware of it. Okay. So anything else like that, okay, we have digestive problems. The greatest category by far and away of side effects are gastrointestinal. Nearly all of them, whether it's vomiting, whether it's diarrhea, whether it's that nasty headache, whether I feel funny. Oh, I don't like to take these. Ugh. I was up all night. I had indigestion. Those are all side effects. They're mostly gastrointestinal in nature. Again, these are the two principal ways we get rid of stuff. The liver is the major detoxifying thing in your body. Okay. The kidney is the way we excrete the vast majority of substances. There's a certain amount of things we excrete in the lungs directly. Alcohol was very famously for the field sobriety test and for doing alcohol in the field. And it's not 100% accurate. It's pretty darn accurate. So all of these things are absolutely true. You certainly have to adjust your dose. And the thing that you'll learn about in nursing, particularly years ago, it was very important because you had to, and you're still going to have you do it. You're going to have to calculate doses. The pharmacy's going to do it. in real life, the pharmacy is going to take care of all that stuff. But it doesn't mean you don't have to know it. The fact that and this is true all over medical fields, the fact that, why do I have to know this stuff if someone else is going to do it? Because you should be very familiar with the process, because it tells you where the pitfalls are and things will go wrong. And the basic way that it's, you'll hear this expression a lot if you haven't heard it by now. Well, this, milligrams per kilogram. That's where we calculate dosages. So depending on what your weight is. So if you weigh, typical average person probably weighs about 70 kilograms, about 154. 2.2 times. So whatever that is, so if it's 5 milligrams per kilogram, okay, you figure out what it is. So if you know the dose is 5 milligrams per kilogram, it's just a ratio. So you can figure out, if you know that they weigh 70, you know the old cross multiply and divide. Remember that thing, ratios, without doing the math? So whatever that be, 350, okay? Something like that. So you don't typically have to worry about it, but you should at least be aware of it, because in the back of your mind it might be, because people make mistakes, and when you're involved in clinical medicine, in patient care, you're almost cross-checking each other. You understand what I mean? I mean, I'd rather avoid the problem than look for somebody to blame. We're in a culture where everybody's looking to assign blame rather than look for what the source of the problem was initially. And a lot of times they say they didn't check close enough. I'm a furious double checker. It's annoying. I'm that person who go out, got it from my dad. Okay. Go out, start the car, start to drive. Oh, I wonder if we turn the heat down. Oh, I want to make sure the stove is off. You know, is the door locked? I'll turn around and drive back. There's another expression for that. Crazy. But we're obsessed. But everybody has their own little obsessions. That's just one of them. So be aware of that. Double check things. Make sure. That's what I mean. It's like, make sure. If you had A&P with me, you talked about the blood thing. How many people does it take to give? You need 2 people to give a transfusion. One person could do it easily. The whole idea is this process of double checking the blood bank, double checking whoever brought it down, making sure you have the right patient ID, da-da-da-da-da-da. Same thing here. It helps to be sure, rather than just it's the old story. It's not that hard to do your job. It's hard to do your job to the best of your ability. So all of these things are true, and there's different criteria. Elderly folks, their systems don't clear things as rapidly. Infants, there's a whole subset of problems that are there. And pregnancy is a remarkably difficult condition to address, because you've got somebody who's not only are there 2 lives involved, but we're dealing with a remarkable amount of steroids that are floating around at very, very high levels, and they impact the way we utilize things. So other things like that, okay, other things that they may be taking or not taking. So you need to be very thorough with regard to this, and understand that you can't, sometimes, there's things that they stick on the bottles when we get them from the pharmacy for you and I. They're there for a reason, but a lot of times in a clinical environment, in a hospital, you need to explain those. Why we take it with food or milk, why we don't take it with food or milk, why we take it after a meal or before a meal. It has to do with stomach acidity. All of those things are important, because that sometimes is a question of, why didn't this work as well as it should? Because people, it's well, I really didn't feel good and I got that prescription for antibiotics. I'll just take 3 today, even though I was supposed to take 1. It doesn't work that way. The emphasis, take things as they are prescribed. They're prescribed that way for a reason, with the appropriate precautions. And people will do that. If 1 works, 6 will be better. It doesn't always work that way. And so all of these things, so understanding the interactions. Again, the pharmacy handles a lot of these things. It doesn't mean that you shouldn't be aware of it. And that's the whole thing for many of you. I'm talking, the nurses and whatever health related. I'm sure they still do them. They're called med cards. Hear about those things where you have to write down the medicines and side effects and the doses and the different names. You won't love it. It's good. Some things don't have to change. Okay? It's like, to me, and it's preachy, but when you're dealing in a medical-based field like this, it's things have stood the test of time. It's foolish to change them that are there. And so doing med cards has been around for forever because it starts to make you familiar with medications. And on the flip side of that, it's like an old thing we say in doctor: see one, do one, teach one. And you'll demonstrate that as well. You'll see somebody start an IV, you'll do the IV, and you'll show somebody else how to do it, and it just puts it into your mind very, very clearly. So these are some hypotheticals. Final choice for a drug is not always easier. So, elderly alcoholic patient with pneumonia caused by Klebsiella. If they've got Klebsiella and pneumonia, that's already a debilitated patient. We'll talk about that in terms of pneumonia. And diminished liver and kidney function, and history of allergy to penicillin. Oh, God. And here, cancer patient with severe systemic candida infection. Candida is a yeast infection. It's the classic agent that causes, and we go through all these. The vaginal yeast infection also causes a condition that I got when I was taking immunosuppressants called thrush, okay, which is in the mouth. You'll see that. The fact if you get them systemically, that is not good. That tells me your immune system is done. So I don't want to be flip about it, but if they're in that kind of a situation, their long-term prognosis is not good. Okay, so which of the following antibody would be the safest choice for a patient with no exceptional medical history? Zone of inhibition, zone of inhibition. I don't know if this is true or not. Oh, therapeutic index. Here we are. 12. Who cares about the zone? Okay. If you didn't have my lab, I'll make the point again. The zone of inhibition is not how much. It's a qualitative test. Okay. Yes, no, maybe. Those are the three things it gives you. It's not a matter of how big the zone is. Bigger is not necessarily better. Therapeutic index is a much wiser choice. Assuming that both of those indicate susceptible, the therapeutic index is the governing field. I don't even care what the stupid PowerPoint says. I yelled about that point in lab. I can't tell it to you strongly enough. If they give you a thing, and you see it if you bridge through the PowerPoint and look through the chapter, they'll talk about what's called minimal inhibitory concentration. That's the dosing information. Okay? Understand that that's where you're dealing with specific amounts that are there. Here, that Kirby-Bauer test does not mean anything. If Dr. Dress doesn't make that point, I understand it. Okay? I treated patients with infections for a quarter of a century. So, other things. The concept of selective toxicity we talked about. The targets we'll probably get to now. Categories of drugs are most selectively toxic. We'll start talking about that. What a narrow spectrum, et cetera, et cetera, et cetera, et cetera. I'll do all that, I promise. Oh my goodness, there's a lot to do here. Okay. So in some way, shape, or form, it's a reasonable goal to expect them to disrupt some kind of process or some kind of structure. In protozoans, it's more involved with processes. Typically with protozoans, we're looking for things that distort their metabolism. When we get to them, you're going to see a lot of protozoans are what we call anaerobic organisms. They function better in an environment without oxygen. So we focus the treatment on them. We'll get to that at the time. Fungi, we have one major target that works. You might remember, I know this is a long time ago. Remember what our cells have. Fungi and protozoan are eukaryotic. They look like our cells. Membrane-bound organelles, nucleus, endoplasmic reticulum, the whole deal. What is in our cell membrane that bacteria don't generally have? They definitely, all bacteria don't have this. We have something called cholesterol, right? There's a limited number of bacteria that have sterols, and we'll get to that are there. But plants have sterols. What fungi have is we all eukaryotic cells have a sterol. The target by far and away of any effective antifungal drug today is this. It's called ergosterol. That is the sterol that is in the cell membrane of yeast and fungi. Mold, whatever, all that stuff we saw in the lab. So, I mean, that's an easy category. Not necessarily an easy category to work with, but it's an easy category to understand what the best agents are. And I'll give you chapter and verse on that because I've probably treated more fungal infections, if possible, than the second to bacterial infections. And then we have bacteria. And bacteria are prokaryotic cells. They have a cell wall. That's a target. Okay? Then they do business like the rest of it. They have a cell wall. Think of the things that make them unique. And we talked about this. The thing that makes it unique is their cell wall and specifically peptidoglycan. After that, we don't have a lot of other structures that are unique. There'll be a couple that you'll see that are different. So the cell wall is the most desirable of all the targets to have. Unfortunately, there's those three little words, allergic to penicillin, that interfere with that. Because penicillin targets peptidoglycan. Okay? Viruses are different. Basically, we have to interfere with them in a couple of different areas. We'll look at that more specifically. We'll take a look at that as well. And I mean, this, again, with viruses, not only replication, but a lot of different things that viruses do. We will look at that. How should I say it? That's where you're going to see a lot of things like protease inhibitors and antiretroviral inhibitors, etc. Okay, destroy structures already formed. I'll buy that. And of course, selectively toxic. So optimally kill or inhibit microbial cells without damaging, good luck, host cells. Here we go. Excellent selective toxicity to block the synthesis of the bacterial cell wall. Penicillins. We don't have peptidoglycan. It's that we pick the one big thing. The only other thing that's in there that helps us to a certain degree, and the next big category are ribosomes. Remember, we have 80S, they have 70S. Unfortunately, we have 70S ribosomes in our mitochondria. That's why antibacterial and antibiotic agents that target ribosomes, or protein synthesis agents, as we generically call them, think that Z-Pak, think tetracycline, okay? Even think things like streptomycin, all different things that you worked with doing that experiment in the lab this week, okay? Problem with them is, that's right, side effects. We'll keep going. Characteristics of the infectious agent are more and more similar to the host cell. Selective toxicity becomes more difficult to achieve. We both have it. Everybody's got a cytoplasmic membrane. It makes a living thing, right? Selectively permeable, phospholipid bilayer, the stuff you learned about ad nauseum in ANP1. So, what are the goals of this? Disrupting the structure or function to the point where it can no longer survive. And that's fine. It doesn't have to be destroyed per se. It's better if we can kill it. That's the whole idea of bactericidal. But even if it's bacteriostatic, if it stops growing, then effectively you have, assuming your immune system is intact, given a sufficient amount of time, it will overcome the problem. I'll say it again and again as we begin now to talk more in earnest about how diseases affect us, be they bacteria or virus or fungi or anything else like that. It's a numbers game. Yes, ma'am.
Like an infection and wait too long to get treated, and therefore bacteria static medicines like just aren't effective.
Yes. They'll still be utilized because they'll be the only choice. We use them because you're almost obligated in the presence of the infection to treat it. You've identified the problem very accurately. They are very, very limited effectiveness. there's going to be damage, and now a lot of after that would be coping with the damage. Maybe limiting the spread of that particular infection. Maybe it's infected, it's created, maybe it's a skin problem, it's created an ulceration or a big sore on the skin. That's not going to heal properly. It's going to leave significant damage, may require plastic surgery, even if we get it under control. Maybe it's internal infection, it's going to cause some kind of organ damage that's going to compromise that patient, if not permanently, at least for a period of time. So that's why early identification and treatment is the key. And it's the biggest problem I had. Remember, I dealt with feet and I dealt with diabetics. One thing, the longer they have diabetes, and you're going to see a ton of diabetic patients, they're afraid. One, you don't even want to look at them. They don't have somebody looking at their feet. I mean, and older people, it's hard to see the bottoms. It's not hard to put a mirror on the floor and be able to look at it that way. They're very reluctant because if they see something bad, they're going to be scared because they think if I go to the doctor, they're going to cut off my leg. So there's a whole lot of teaching that goes on. And it's one thing you have to tell people, it doesn't have to be diabetes, anything that puts them at risk, bad circulation of any type, checkered medical history of any type, faulty immune system of any type. Don't wait. The best chance we have of helping you is now. And this is what I told them. I mean, I had a solo practice. It was me, myself, and I were treating patients. I was good, but me and myself we're not on top of their game. So you got a little smile out of you. Yes.
So at what point does it become sepsis? Like if you wait too long, does every infection?
Theoretically, yes.
Okay.
Theoretically. So sepsis means it's out of control, effectively. And so, as I said, it's a numbers game. Once the numbers begin to overwhelm your immunological capability, now you have big trouble. And then you're going to have, certainly at the very least, tangible damage or a prolonged hospitalization or a prolonged recovery period. And whatever you're going to use, you're going to have to use more toxic, more potentially harmful methods to deal with it. So the best point of anybody like that you identify, it doesn't have to be a patient if you're not going into a medical field. It could be your grandma, it could be your uncle, it could be your mom and dad, it could be you. Get help now. I mean, I'm not saying that it's a panacea. I mean, I have my own feeling about certain medical types of things. Urgent cares to me are good for little problems. If I have an underlying disease that's significant, I'd rather go to the emergency room. Then we have the time constraint and the weight, cost is a factor. All of these things. That's what medicine is like today. And the bills are astonishing. My son started a new job Monday, and he's calling me. And I know he's got a habit of using. He doesn't feel good. He's running to the emergency room. He said, "Which plan should I take? This or that?" I said, "Which is the high deductible plan?" And he goes, "This one." I said, "Don't take that because the bills will be astonishing." And a lot of people are saying, "Money is an issue." You're not going to forget about all that money you owe them. They just don't like that. What people don't understand is hospitals. They can't charge interest. They can just hound you to death, but they can't charge interest. It's not like the bank. It's not like the car loan. It's not like Uncle Sam. So these are all, I mean, this is morphing into a lecture based on your question alone. All of those things, the cost of I had patients, they couldn't. This is long before our health insurance covered. But this is long before the state had programs. It was originally called the PACE program, where people on a fixed income that was limited in the state of Pennsylvania. It was like a Pennsylvania Assist something, where they could get a certain amount of their prescriptions without having to pay more than a couple of bucks. I can't tell you how much I get. I can't afford that. Sometimes I had to pick the agent based on their budget, which is, at least they're taking something. There's a whole lot of. The preachy point is that depending on where you're doing things, understand everybody's got problems, and you have to be sensitive to them. And it's hard, and they'll be more willing to tell you depending on how your approach is. Okay. Don't be one of those people, and I hate to talk about nurses. I was having a urological procedure. My son had driven me because I had to have someone drive me. They always tell you this. I was Allegheny General. Where's your driver? That was immediately. Don't ever talk to me like that. Don't interrogate me. Ask me politely. He's asleep in the car. I'll hit him on the cell phone when he's ready because he's 18 years old. The last thing he wants is, he's ready about me. Getting a whole lecture. I said, fine. Point noted. And she continues to give me these evil eyes. They're wheeling me down to the staging area. I'm talking to whoever the aide is and whoever's accompanying me. I said, does she always have that broomstick up her ass? Because she ought to get rid of it because it's going to hurt her the way she walks. Don't be like that because people will have nothing to do with you. Don't be like that. I mean, unless it depends on the patient. Again, I'm not the patient you want. You can't talk to me like that. I just did. I told you to blank yourself. And the horse approached you. I don't appreciate being talked to like that. Well, then don't talk to me that way. Speak to me politely. I'll answer you politely. And that I'm older than you are, considerably. I digress. So, point taken from your interesting question, Allie. The way of the world is try to get them to take it early. You said, I think you have to coach people. Again, I'm not a tremendously large fan. We've had some really good treatment at urgent cares. I mean, during COVID, my wife she got a tick bite. She ends up with Lyme disease. It was clear they made the diagnosis was easy. Don't get me wrong. Very effective treatment at the urgent care. I mean, there was all sorts of issues going to the hospital with COVID. Oh my God, I mean, I was still sitting in the car when she went in because they're swabbing everybody to see. Oh my God. Over the top. Digress. Okay, so here's their categories. Best cell wall. Nearly all of them target peptidoglycan in some way, shape, or form. Nucleic acid structures and functions. Surprisingly enough, there's a couple of good medicines in this as well. Okay, it's interesting. The one, did you use, people at my lab did ciprofloxacin? Okay, Cipro works in this department. It's interesting why, since we all have DNA, it happens to work on an enzyme that's unique to bacteria involved in DNA. Just say. The next biggest category, maybe by number, the category that has the most things in it, protein synthesis. Again, ripe with side effects. Very little, all things have a cytoplasmic membrane. Those, now we're starting to look at drugs of last resort or drugs that we only use topically. Historically, you should be familiar with the 3 agents that make up triple antibiotic. If nothing else, it was designed here in Pittsburgh. Okay, just say neomycin, which is you're going to learn is called an aminoglycoside, because you probably use streptomycin, right, on your plates, right? We did. Neomycin, the reason we don't take that, or it's too strong. Okay, bacitracin, which actually works on the cell wall, it's too strong to use orally or injectably. And lastly, polymyxin B, that works on cell membranes. And there's a very, very, very limited way. That's like the last choice, using something in the polymyxin B category to use if all else fails. We'll talk about some of those things going on. So we put them together and make triple antibiotic ointment. What you'll learn is, for diabetics, we found out that neomycin tended to irritate a fair percentage of that. This is a golden point to remember. So next time you have somebody in your orbit who's a diabetic or a patient, and say, well, they told me to get triple antibiotic ointment. Don't. They're a diabetic. You can get bacitracin ointment. You can get something. They had another one that was, its name was polysporin. And now they're all available. Those are the trade names. They're available because they took out the neomycin and it caused a terrible rash on diabetics. Not all of them, but enough of them that you didn't want to. You're inviting a problem you didn't need to have. Because topical antibiotic ointments do not treat infections per se. They prevent them from getting worse topically, or prevent an infection from developing an area that may be predisposed to it. So you're getting the idea, if nothing else from this little discussion, I know a lot about this stuff. And I do. Without patting myself too hard on the back. Cytoplasmic, but here's an interesting one. Folic acid. Where did you hear about folic acid recently? You had me for A&P, you probably heard about it. What's it do? One of the anemias, right? B12 and folic acid help red blood cells mature. Folic acid is something that we use to make DNA. We have to have it for DNA. For us, it's essential, which means we have to get it through our diet. We don't make it. How about that? This is a hidden category that became jet. Okay? Bacteria actually make their own folic acid. They have a folic acid pathway. Us, as far as I know, carry in general, humans, animals, I'll just say humans, don't! We have folic acid, that should be acquired by diet. That's selective toxicity 101. This is something that we have to get. Bacteria have, so if we interfere with that pathway, it should have very minimal effect on us. It's true, it does. This is one of the earlier agents that was discovered. It's not really, when I get to it, we're going to look at folic acid inhibitors. I'll just give you a heads up going forward. And they were one of the early antibacterial agents because they really did not come from bacteria or mold. So it's the go-to drug for easy to treat urinary tract infections. You hear the trade name Bactrim or Septra. We'll go into it some length. Magically, years ago, when we didn't have a lot of choices, they used it a lot. Had some side effects. Used it excessively. Then, because of the side effects, it fell out of favor. And when MRSA reared its ugly head, guess what? They were trying every antibiotic they had anywhere. Pharmacy. They found that folic acid inhibitors were a go-to choice for something you're going to learn about called community-acquired. So the same agents that we're using to treat relatively minor urinary tract infections, mostly in women, were like magic for community-acquired MRSA. It's like the way I would describe it is out of sight, out of mind. The bacteria hadn't been exposed to it, and all of a sudden it's like, what in heaven's name are you treating me with? Are you attacking me with now? I've never seen this before, even though it's been around for 100 years. Go figure. I love doing this. Yes, ma'am.
In terms of resistance, will the bacteria developed like a parallel pathway to make folic acid?
No. But I mean, they've not developed a parallel pathway per se. They have other ways to combat it. Okay, you're going to learn about a lot of bacteria have magical mechanisms. They make enzymes to break apart the agent that they're treating it with. They have what are called efflux pumps. They actually have pumping mechanisms to push it out. Okay? They change subtly the enzymes which are the target that still work in the pathway but don't. Pretty clever for a single-celled organism. What that underscores is they're living things. And living things, the one thing living things do universally, no matter whether they're single-celled or like us, multi-celled and allegedly intelligent, okay? They try to survive. So that's what we do. Which is why I keep using that yes dear thing. Survival of the Ooh, is that ugly? Look at that. I mean, I wouldn't want to make that in a dark alley in the middle of the night. She's always made me wonder why my daughter went to the South Side so much. Only one time, did I tell you? Only one time did it really impact her because she had drunk so much. There's no saying when you got to go, you got to go. She did. Oops, she got cited. Dude, don't be that way with your dads. It's like I didn't get excited. My ex is like, oh, you know, in your head against something. She said, "Oh, your kids, get over it. It's not the end of the world. Listen." Okay, here they go. Protein synthesis. So synthesis, you don't have to, I'm just gonna laundry list them here. You don't have to write them down. Zithromycin, the Z pack. You're gonna encounter this agent constantly. If you haven't already been prescribed it, people will ask you about it. Okay, it works on, you don't have to know what subunit, whether it's the 50 or the 30 or both. Okay, but these are agents that work on protein synthesis. A very interesting agent that we'll talk about, you might remember me saying that sometimes it's tough to penetrate the glycocalyx, like an implanted orthopedic materials, like screws, pins, metallic hardware, etc. Clindamycin. I use a lot of it. Big side effects. The big problem with all of these side effects. We'll deal with all of them. And these both significant. An interesting story about azithromycin when we get to it. Clindamycin, notoriously bad on stomach acid.
Do they, topically, do they prescribe that?
Clindo? They might, I don't know. They've used the two agents I'm familiar with acne, that they do mini doses, are oral. So their tetracyclines are used and erythromycin is used. Oral. Topically, I don't know. I always thought they used most of the topicals were vitamin A acid derivatives, like retinols. That area.
I've been prescribed it for pimples and stuff. Yeah.
Is it what, Clindo? It's very strong internal. So you know the patient's going to get horrible diarrhea, and so you have to take steps. Right? Because of that, what do we do when we know that's going to happen? If it's compatible, we tell them right now, take it with milk. Take it if you can. Eat yogurt. Okay. Buttermilk's not necessarily a fan. Milk, Asians with probiotics, taking them, cottage cheese, ricotta cheese, those types of things inherently things that help it. I do prescribe a lot of yogurt. Things like that. I like yogurt. Bus, play, Blazing Saddles. No, Spaceballs the movie. Just Play Yogurt. Did you see the movie? We'll play the play. Just Play Yogurt. I'm a stranger in a strange way.
What's the movie called?
Spaceballs.
Oh, I've heard of it. I've heard of it.
You heard of it? You didn't see it? And you got me for a t-shirt?
I think we should watch it.
Oh, yeah, it's a class exercise. They throw in here some stuff today that is not politically correct and so on.
We're in college.
That doesn't matter. I couldn't do Blazing Saddles because they
Instead of the piracy movies, are they gonna start instead of piracy movies, are they gonna start putting
I'm sure they will.
Culturally appropriate for today.
Oh, well, did you ever watch on TV that says they're smoking, alcohol use? Nobody smokes? I mean, people, thank goodness they smoke. Okay, now, so there, look at all of these. Important agents, aminoglycosides, that's the streptomycin we don't use very much. Gentamicin, you'll have to learn a lot about. That's the drug of choice for something called Pseudomonas aeruginosa. Pseudomonas is the worst nightmare for a lot of it. Very hard. Very hard. Tetracyclines. Okay? They're in this, and I'll talk about some of the other ones that are in here. Over here, all the good guys, but they're not all good to use. Penicillins and cephalosporins to me are the best categories. Vancomycin we use very limitedly because we overuse it. I'll talk more about that. I mentioned that in passing. This is something we use for tuberculosis, just to give you a laundry list. So this is membranes. These are called colistins. The one in this category, this daptomycin, very, very limited. It's one of those last resort drugs. Then here, quinolones, rifampin is very strong, and we use it for tuberculosis. I'm going to go over all these again. And the quinolones that happen to play a role with DNA raveling and unraveling are a very good choice, as I will go into at some length, just to give you some ideas of where we're heading with all of this discussion. So we will look at all of these that are there. No, I mean, this is the one, that one, cefaclor. It should have an O in there, but I digress. Known as Ceclor. Cephalexin, which originally came out as Keflex. I mean, you don't have to know those now, but you can see so many of those. And I said it to my class, and I will say it to my lab, and I'll say it to you. More than half the prescriptions for antibiotics prescribed in this country are right here in that category. So it behooves you to know those the best. We'll look at the penicillins. We'll look at all these, but I won't start it now. Goodbye. Have a great break. I'll get those things posted for you.